May I request Dr. Partha? He requires no introduction. He is the chairman of scientific committee and has got very long experience of the use of a variety of lenses, PK lenses, and he will be speaking on the correct way to do ICL and Toric ICL.
Thank you very much, Dr. Bazin. And it's been a wonderful way the IC has been dealt and been accepted all over the years, as well as internationally also this IC is acceptable. So it is a very nice way of putting forth that how do we go ahead and do the correct way to do an ICL and a toric ICL. So with all the background that already has been said, I will just stick to my points of doing ICL the right way. So I'll straight away play the video in which we have the ICL and how to do it the correct way. And the correct way is very important. If it is not done the correct way, then it cannot be done rightly and the results are very, very poor. So topical anesthesia for one is very important. No peribulbar anesthesia. The loading of the haptic of the ICL is most important, and the loading has to be done in the cartridge, half filled with methyl cellulose as viscoelastic, taking off any bubbles in the cartridge itself and removing any bubbles that can come into the way, because that can go into the anterior chamber and occlude the view. So the next thing is removing the ICL from this container, and the container is in BSS. So this ICL is not going to expand in its dimensions once it is placed in the eye, which means that once it is placed in the eye, next day itself, you can understand that this is the vault, more, less, or optimal. Now, picking up with this applicator, and this is a very important applicator, do not use any other applicator than this, and then placing it very gently into the cartridge. It should not dehydrate during the process of the implantation, and thereby, if the time elapsed is more, then please put a drop of BSS on the ICL. Now, it is nudged in very gently, it will go in, and this is the Osdor forceps, which is supplied by the manufacturer to grasp it. And the grasp is important because it should grasp right in the middle, and there is a small hole in the middle. The grasping part of the forceps should part on that hole, and then drawing it very gently across. Both should move. The applicator should move as well as the forceps should move. So, and that is how very atraumatically it comes near the hub, but not beyond the end of the cartridge. Then it is placed into this cartridge and locked in. Once that is done, this should be dipped into the BSS once again and kept. Then comes the incisions. Do not make incisions before, or do not place in viscoelastic into the eye before loading the ICL, and it has to be done as atraumatically as possible. 2 side ports have to be made, and once the side ports are made, the amount of viscoelastic that you need to place in the anterior chamber should be just optimal. Now, what viscoelastic? The first viscoelastic that we have been using is methyl cellulose, but you can also use Helon, because Helon comes out in a bulk from the anterior chamber, and the amount of incision should be 3.2. This is one of my very initial videos where I had extended this 2.2 millimeters to 3.2, but it can go into 2.8 as well. So placing it in the anterior chamber and watching it unfold, and moving the cartridge a little as it unfolds so that the top hole is right on the top, and then pressing against the iris in the anterior chamber, not putting it behind the iris in the first go at all. So that these small tricks have to be kept in mind. And then the haptics are very, very simple, very small haptics, which just have to be tucked in. And the manipulator again has a curve which should be tucked in with the right way. No vigorous manipulations at all, and then the viscoelastic needs to be washed out. Now, washing out the viscoelastic is important as much as possible. The helon can come up in a go. The methyl cellulose needs to be taken up. At one time, it was thought that the central hole, which can flush out the methyl cellulose, can be taken off very simply, but it is best not to jet on that central hole, because it's been found that cataractus changes might take place if there's a jet going down for a very long time. So it's very simple, that's it, and good closure. But what is important is also the post-operative checkup. The first day, some people do it on the same day as well and see the vault. But the first day checkup is very important. The vault should be assessed, and it should be at least approximately 500 microns, 250 to 750 is acceptable. A little more or a little less can also get away, but you have to keep these patients on a check. And if you have done a toric ICL, it has to be in the proper position. At times, the movement can be there, but it's very, very rare. It stays very nicely in place. But if a movement has been there and the patient has lost vision and there is a decrease of vision in the first week, it needs to be retaken up for surgical maneuver, and it has to be placed in the correct axis. So wishful thinking that it will go back on its own is not correct. Unless it is a very small ICL and it has rotated quite a lot, then only needs to be taken out, otherwise not. So a toric ICL, if you have a markerless system in your theater, it is best to use the markerless system. If you do not have, even manual marking can do. For many years, I used the manual marking, and now we have the Callisto. So Callisto gives us a lot of advantage. It's very important that, with dilatation, you can see both the toric marks, and that makes it quite easy to assess whether everything is fine. So these are a few things that I wanted to share with you. Post-operative examination is very important. An intraocular pressure check is important. Usually we don't do it the first day unless there's corneal edema or anything. So 1 week measurement of the intraocular pressure is quite okay. But if the intraocular pressure is greater than 24 millimeters of mercury, or 10 millimeters greater than the pre-op, then that needs to be taken into account. And the IOP elevation is usually because of two reasons. One is retained methyl cellulose or retained viscoelastic, and the other is, if it has occurred a week later or so, it can be a steroid responder. For most myopes, for a percentage as high as 15 to 20% of myopes can be steroid responders, and this has to be kept in mind. And if that is so, then of course it has to be taken a call. What about iridotomies or iridectomies? We do not do iridectomies as of now, except if it is a hyperopic ICL. And of course, the PI should be checked if it is required. And these are a few slides just to show that if the PI has to be done, it has a very peripheral PI, but a large and a patent PI as such, which we usually do not do anymore. Now, if there is a high vault of the ICL, and this has to be taken into account, and these have to be washed. But if it goes from 750 to 800, 850, and the intraocular pressure is well maintained, and of course with these current ICL with the central flow, there's not a PI. We don't have to rush in to do a PI. We just have to keep a watch on the intraocular pressure, and gonio can be done intermittently. However, if there is an ICL with a low vault, so how low is low? So if it is less than 250, if it is in the range of 200 to 250, you can just very safely watch. If it is coming down, say in 2 months' time it is 200, and then in 6 months' time it is around 100 or 150, these are patients to be washed off. If it comes to less than 100, this lens definitely has to be removed. So the removal is not so difficult, and it's with the same incision that you can go in. A 3.2 can remove it very well, very atraumatically, and you can put in the correct size of the lens. However, if there is a low vault, In the first week itself, less than 100, that means the sizing has not been correct and this has to be replaced. Thank you very much for your patience here.